We're interviewing really one of the pioneers in implant regenerative dentistry. Jack's been one of my teachers early on, and now a colleague for many years, has been at the forefront of leading-edge technologies and regeneration, periodontally regeneration, and of course towards implants. And lately he's been doing something very, very exciting, guided surgery for implant placement with immediate loading. And I'd like to talk to Jack a little bit about where he's at with that concept and where it's going and why he started.
Thank you, Maurice, for having me. Very nice to be here with this little talk show. I found that the guided surgery for immediate loading has been a culmination of many years and many aspects of implant dentistry. We've taken improvements in implant surfaces, the treatment planning concepts, the team approach, where we've done a lot of work with our laboratory colleagues. There's a lot of pre-prosthetic planning. And then with the use of computer planning, it's become very exciting, a lot of fun, and we're able to precisely position implants. We can get a resin CAD/CAM model that can be placed into a patient's mouth, customized for their needs, and we could then create a surgery with a tremendously reduced amount of time, minimally invasive, a flapless approach. And if we choose, we can actually take this guide prior to the surgery, work with some sophisticated technologies using titanium milled bars, and our laboratory teammates can create a framework upon which either porcelain or acrylic resin teeth can be baked onto this titanium frame. The fit is amazing. The amount of steps on the restorative side that it eliminates are phenomenal. I mean, a restorative teammate would come with me at the time of the surgery, and their work would be less than a half hour.
Predominantly, is this used for fully edentulous patients we're talking about, predominantly? And what kind of communication do you need with your restorative and laboratory colleagues in order to implement this type of computer-generated treatment plan?
Well, you bring up the communication between the team. I think that's critically important, because the way this system works is the computer actually translates the pre-prosthetic design that's been created by our restorative teammate to the laboratory technician, so they'll know in advance the contours, any flanges, lip support, and all the occlusal aspects that are necessary, vertical dimension. All these things are done before we even plan out the case.
So you have a wax up and a stent, radiographic stent, that's taken with the CT scan?
Yes, a very specific guide is made for the cone beam CT.
Correct.
Now, I'd like to make one point, that you cannot use a device that has a soft reline in it. So if the denture has been made ideal with contours and aesthetics for the patient, but it has a soft line, the restorative teammate should make a clear duplicate of that, because the software programs don't want to see the difference between the soft line material and the hard acrylic. So we're working with hard acrylic. Clear duplicate is perfectly fine.
Right.
Then a series of markers are placed onto that appliance, and then the patient gets a scan with either a CT or a cone beam CT to find the relationships of the denture in their mouth. A second scan is done of just the prosthesis alone.
Correct.
Now the software is going to look for the markers and will line everything up.
They'll actually put the denture onto the bone for you on the computer.
Right. In the reformation of this through the CAD/CAM process,
right,
a jaw of the patient will be created, and then they'll know the soft tissue thickness because of the double scanning, and then a virtual denture will go on and off at the planning software stage. Right. So you load this into the planning software, and then you could create the exact positions that you would like.
Do you show this treatment plan to the restorative dentist before you actually finalize it and send it for processing? And is the lab that needs to work on this, does it have to be a Noble lab, or is there accredited labs in the United States that can do this for you?
Well, it's either way. If you're doing the product called Nobel Guide, the laboratory technicians are trained to work with that titanium milled bar that I mentioned earlier.
Correct.
And that comes from the Procera technology for the laboratory colleagues using their Forte scanner.
Right.
So while most labs could be trained, they're all not trained at the moment.
Correct.
And it is a very precise discipline. So the restorative teammates do have input at the case. When I do the planning, I could save it, bring them in, we could look at it, we could tweak it, we could move the implants around, we could adjust it, we could add more implants if we feel like it. We could discuss, what's very important is whether we're going to go to a final prosthesis, a provisional prosthesis, or just keep the implants in a semi-buried state and go back to their complete denture prosthesis.
So you're not committed to doing it as an immediate load, provisional or final prosthesis?
No, you're not forced to, but you can, and when you do that, it's a very beautiful and simplified and predictable way. However, we found that there are cases based on bone quality where we may not want to do an immediate load, and we want to get a precise placement of the implant. So we get the benefit of the precision in the placement, yet we don't have to compromise the biology that we know over the years some areas are soft. You don't want to do the immediate load there.
Are you using Hounsfield units to give you an idea of bone quality as a limiting factor, or are you using just the feel of the drill? And when, in some cases, do you make a decision not to do a punch through the tissue in an incisionless approach? When do you actually decide that maybe you need to do a flap in this case, whether it be for keratinized tissue or because you need some bone grafting?
Well, that's a lot of important questions piled on. Right. Yes, we do use Hounsfield units of density. When we're at the planning stages, there's an icon that we click on, and it will give you an exact Hounsfield reading of that particular area. So I generally position my implants, and I generally will scan several areas to see what the Hounsfield units are.
Correct.
My experience so far is that the computer does do it very accurately, and I'll know that the area is going to be soft, and it then turns out to be soft.
Correct.
We modify our surgical protocol then, but we'll talk about that in a little while.
On your lecture.
Yeah.
Is there a Hounsfield cutoff that you have where you'll say, if I don't have 400 Hounsfield or above, I'm not loading that implant? Do you have, have you created that, or have you felt that there's a limit, or really it's depending upon the situation?
Not one particular number, because I'll generally, if it's a full maxillary case, I might do a scan and check 14 or 16 points.
Right.
So I get like an aggregate concept of how that case is going to go, whether it's a soft bone.
Sure.
Now, there may actually be one site that's quite soft, and the others are fine. So we note that. We tell our teammate, do not load that implant. So we can still go to a load and have an implant that will be loaded a little bit later on. So it's sort of a progressive case.
How much does this add to the cost? A lot of people out there are going to be wanting to know, well, I'd love to do this. I'd like to go and learn it, because you do have to go to courses and get approved for this method, because not that as much as it's so complex, but it is different than what we have done routinely in dentistry, utilizing Implant technology, Materialize, or a VIP software. There's a lot of different competitors out there. This is a different process, and you need to learn it. You do a great job giving the courses. I've sat in on one of them. What is the added cost, would you think, to somebody saying, if I want to perform this, what is it going to do from a financial standpoint?